Welcome, everyone. Sorry I didn't get a ding that there were people in the waiting room. Hope everyone's having a good week. So, how do you all take turns during holidays? Do you all like rotate holidays off, or is there a general rule or a way that you all support each other to have any kind of holidays? Thank you, Shannon. Thank you, Shirley and Diesta.
Justin, were you talking to us?
I just asked, so we just had a holiday week, and I realized that I had a 3 day weekend, and I can't assume that any of you had a 3 day weekend. So, how do you all rotate holidays so there's some kind of fairness? Does that happen?
If we have another RN scheduled, we give it to them. And me and Diesta take off the holiday. It's fair for us, but not for them.
Okay, I mean, sometimes it's good to be the queen. I never want to take it for granted that people get a 3 day weekend occasionally.
And between me and Diesta, we just would take turns.
Okay. Do you all have to arm wrestle or anything?
No, she's my boss.
Oh, okay. Well, I mean, Diesta probably doesn't want me giving you any ideas. Welcome, Ifat.
Hi, how are you?
Good. How are you?
I'm doing good.
Good. Welcome, Susan. I hope you're having a good week.
I wanted to ask about the certificate.
Yes. How can I help you?
I haven't had the chance to even open and start working on it.
So let me give you my email address, and we'll sort it out and see how I can help you.
Okay, thank you.
Okay. Yeah.
Perfect.
So just shoot me an email, and I'll connect you with Jennifer, and we'll see what we can do to support you.
Thank you so much. Is it GN01?
JAMA, G is in George, N is in Nancy, 01. Yes.
All right, thank you.
Hey, Susan.
Hello.
Susan, did you email me about the Mose form?
I did. Does that have to be a certain color when you print them off?
So that is an excellent question. So we just had legislation changes in Kentucky that took effect July 1st that it can be printed on any color paper. It used to be pink, but now you can print it on any paper. And we're going to start the Mose Coalition. I coordinate the Most Coalition, so I'm pretty intimately involved with most. So those of you in North Carolina and other states, you probably have I think you have most in North Carolina. I don't know what you have in Massachusetts. But our medical order for scope of treatment form can be printed on any color paper now, and you can honor electronic versions. So that's a pretty big shift from the last legislative session.
Thank you for the update.
Sure. Yeah, we're going to be working on updating our website and doing some education around that. We sort of had to wait for the Kentucky Medical Licensure Board to get it on their website. Shirley, do you all use, you have most in North Carolina? It's an advanced care planning, or well, it's a medical order, but it's kind of an advanced care planning tool.
No, we're in Kentucky.
Oh, you're in Kentucky.
But
Oh, I'm sorry.
yeah,
You're at NIM. I'm sorry. My brain was putting you in North Carolina, but so you all have the most form as well. Do you all use it?
we don't. We're still, everything we have is still paper chart.
Okay. Have you ever used the most form?
I don't think so. DS is saying no either.
Okay, so it's. I'll send you a copy of it. It's a medical order for scope of treatment. It accompanies an advanced directive, and it gets into greater detail around levels of care around nutrition, hydration, and because it's a medical order, it should be honored outside of. So if somebody's being transported to a hospital and they're adamant they don't want to be resuscitated, it should be honored.
We use something like a comfort measures paper, and it does all the same thing. It tells us all the things that the family or the resident has wished to happen.
Okay.
It's not Mo's, but we have something like that.
Okay. Well, I can send you more information about the Mo's form if you're interested.
Thank
Hey,
you.
Chris. Welcome, Scott.
Were y'all starting to talk about advanced care planning? Charlie?
Yeah, we were. So Susan had emailed me about our MOST form, not realizing that I coordinate our MOST coalition. So
Ah,
it's I don't. North Carolina is maybe a little bigger than Kentucky, but you're always a stone's throw away from somebody who knows somebody in Kentucky.
yeah, one of my favorite things to do actually, Justin, is to connect people like that. I'm a serial networker.
Yeah, if I had a magic power before COVID, I would say that that was probably one of my magic powers.
Do you have a magic power now after COVID or during COVID, however you'd like to conceptualize that? Mine was not getting COVID, but then I got it. So
That was so we're in the same camp. That was I felt really good about not getting it for 2.5 years, and then I got struck down right after Derby.
no, I
Welcome,
thought that was
everyone.
I thought it was because we sent you to the American Geriatric Society meeting.
I got it right before I left,
Oh, okay.
not knowing that I had it.
Can't blame it on work then.
Welcome everyone who's joining. We'll be getting started in just a few minutes. Hope everybody is in a place that has working air conditioning. It is brutally hot.
Yeah, my mom's air conditioning went out the other day, but we got it fixed, fortunately.
Welcome everyone. Thank you for everybody who signed in. If you haven't done so, if you could sign in with yourself and anybody who's with you. Welcome, Miss Gordon.
Hello, good afternoon.
Welcome, Danelle and Pam.
Hi there.
So we will be, thank you, Barbara. So welcome everyone to Project Echo Flourish Connect. We appreciate you being here. And again, this is week 23. We'll be talking about health disparities and social determinants of health. And we will be, next week will be week 24, and that's will be our final weekly session of Project Echo Flourish Connect. We'll be moving to monthly sessions on the first Thursday of the month. We'll be following up with an email about that. We appreciate everyone who was able to give us feedback last week around some topics that you had some interest around, and we hold the morning session. And so it seems like there's some interest between the two groups that kind of overlap. So we'll be following up with those upcoming topics. We really appreciate the feedback. And so now I'm going to ask Pam to talk a little bit about an email that some of you will be receiving around advanced care planning.
Thanks, Justin. So hi, everyone. Supposedly, a email should have come to you that was asking for a Flourish Connect advanced care planning data request. So I sent it again. So we sent it last week, and then we sent it again, I think today around 9:30 in the morning. So it may have actually gone to spam or your trash or something like that. So you might want to go into your email and check to see if there's a Flourish Connect. The point of the advanced care planning data request is that we are both required by HRSA and we're interested in seeing the impact of our training on changes in the way that we're doing advanced care planning in our facilities. So the point of this particular data request is that it's a baseline survey, just asking about where we are right now in hopes that the work that we're going to do in the maintenance phase on advanced care planning will have an impact on the work that you're doing in your organization. So that's the point of it. We are hoping that we get the information by July 13th. The time period is from June 1 to June 30. So we're just asking you to do this for a 30-day period, just a 30 days. That's it. And we're going to be asking you for about 4 things, 4 numbers. The first number is the number of residents that are 65 plus in a skilled nursing unit. This would be not hospice. And then the next question is asking of those, which residents who have an advanced care plan documented in the medical record. And then the residents who do not have an advanced care plan, but do have a surrogate decision maker documented in the medical record. And then the third group is the residents with documentation in the medical record that an advanced care plan was discussed, but the resident chose not to either complete any form or name a surrogate decision maker or provide that plan. Okay, so those are kind of the things. We'll be asking a few other questions about when you actually do advanced care planning. So the lucky ones who get this, it went to the nurse administrator or the data analyst that was identified during the orientation survey way back before we had week 1. And so we only need 1 individual to complete. We do ask that you look for it in your email and just type in Flourish Connect, all one word, data request, and you should be able to find it in your email. If you happen to have any questions, you are welcome to reach out to myself, Pam Yankulev, or Ellen Roberts. And I just wanted to show you kind of a picture of what it's going to have. This is kind of the bottom part of the Qualtrics survey that's coming your way, where we asked for just those four particular data points, and it's all in aggregate, not asking for the name of your residence by any means. And then above it asks you just to verify your name and kind of your process by which advanced care planning happens in your organization. So that's it. That's the request. We hope it's going to be very quick because it's a 30-day request instead of some of our crazier requests. And did you guys have any questions about that? We have had some activity on the survey, so I thank you for those individuals who've been able to complete the survey. And I am here, so if you have any questions and you're thinking through things, just go on and put it in the chat, and I'll see if I can respond to it. Or as I said, you can email me, and I will put my email in the chat. Thank you.
Thank you, Pam. As always, there is a short survey at the end of today's session. Today is week 23. And today's presenter has nothing to disclose. So now I will turn it over to Barbara Gordon.
Good afternoon, everyone. Today's topic is social determinants of health and long-term care. Happy to be with you all this afternoon. Hopefully, this will be enlightening, informing, and maybe even educational. So today's goal is to discuss social determinants of health and their relationship with long-term care. And I'd like to just start here with just giving a overview of the impact of social determinants of health. You know, what do they have to do with nursing facilities? Why should we even be discussing this? Why are we concerned about social determinants of health? And I'll give a lot of information and data during this presentation, just, you know, for context sake, but I know many of you've probably heard this discussion about social determinants of health over the past several years. It's very, very prominent and prevalent in healthcare in terms of trying to figure out what to do about this knowledge that we have as it relates to social determinants of health. I've worked in the field of community-based services, worked with nursing facilities and other entities for many, many, many years, a few decades actually. And back then, as they may say, we may not have called it social determinants of health, but I believe anyone who's been in the field of working with vulnerable populations, we know that this has been an issue, that this has been social determinants of health have impacted health outcomes since you've been working with these particular populations. So again, we're going to focus on this particular topic this afternoon. Definitely want you all to ask questions if you have any questions, to share and participate with your own knowledge and experience during this presentation. I think it can definitely be beneficial to all of us. So as we know, health is more than healthcare. There are societal factors that impact an individual's health regardless of age, gender, race, or ethnicity. Perhaps the most important thing for us to know about societal factors is that they make up a staggering 80% of our health and health outcomes. So if we look at this particular slide, you can see here that roughly 40% is attributed to socioeconomic factors, 10% to our physical environment, 30% to health behaviors. That's that 80% of social determinants. That's that 80% of health outcomes as it relates to how healthy or how not so healthy we might be at any given time. 20% is attributed to clinical care. That's that last circle at the end, access to quality health care. Only 20% of these overall health determinant categories is attributed to that. So in other words, health is more than just health care. Health is significantly more than just health care. That means we need to think and act beyond the walls of the hospital, beyond the walls of any healthcare system, including nursing facilities. These challenges can affect anyone, regardless of age, gender, or race. And I'll give some additional information as we go through that helps to define social determinants of health and the different categories and the impact that they may have on any one of us. This particular version or view comes from the county health rankings that, this is available to anyone to look at and to research and learn more about. There's a lot of information today that discuss this phenomenon, this whole area of social determinants. And there's a lot of research that have been going on to try to help us understand better and to hopefully influence and inform decision-making, particular policy decision-making. So what are social determinants of health? Before I actually read this definition, and you can begin to read it yourself here, I just wanted to give a case scenario, and it actually includes two case examples. We didn't receive any cases specific to your facilities this week, so I'd like to share this just for perspective's sake and to hopefully stimulate some thoughts and thinking from each of you as well. So we have two patients that we're going to be considering in this particular case discussion. Mr. Martin and Mr. Jones. And these can be any two of residents that you have worked with over the years or even recently. Mr. Martin and Mr. Jones are both in the hospital. They have both had some medical care and treatment over the past several days or weeks and are at the point of being discharged. Mr. Martin is 72 years old, Black individual who is socioeconomically, if I can get that word out, disadvantaged. Low income, in other words. He's worked all of his life, but primarily worked as a janitor in a school system, making low wages most of his life. He has Medicaid, Medicare. He's dually eligible. And has both Medicaid and Medicare. His wife died 10 years ago. He lives alone. He does not have a strong support system, doesn't have a lot of people in his life or who are available to provide him with assistance. When he goes home, he's challenged in many ways, including his chronic health conditions, and is ready to be discharged to a nursing facility for care, temporary care, for a variety of reasons. Mr. Jones is 82 years old. He was also in the hospital for whatever medical care that he was receiving, and also needs to be discharged to a nursing facility for a short stay, 30-day stay, hopefully, to be discharged back home. Both of these gentlemen were to be discharged back home after their intermittent stay at the nursing facility. Mr. Jones' wife is still alive and she's his primary caregiver. He worked most of his professional career at a law firm, has really good insurance, not just the Medicare, Medicaid, not Medicaid at all, not just the Medicare, but a good Medicare Advantage plan with supplemental insurance, including long-term care insurance, et cetera. He has a huge circle of supports, live in a nice community where neighbors help neighbors, et cetera, et cetera. So he has really good supports when he go home, especially and including his wife, who is his primary caregiver, who's in relatively good health and able to continue to care for him. So they were both discharged to the nursing facility. Now it's time for them to transition back to home. And the nursing facility has to make decisions about whether it's going to be safe for both of these gentlemen to go home, what supports they have, their ability to go to and from their healthcare appointments with their primary care provider and any other specialists that they may be seeing, their ability to manage their medications or have support there to manage their medications for a long-term period of time. They are both discharged from the nursing facility to home because Mr. Martin, although he doesn't have really good supports at home, he does not want to stay in the nursing facility. He wants to go home. And of course, you all can think about what happens next. And I'd love to hear from you in terms of if you've had similar situations and what do you think might happen with Mr. Martin and Mr. Jones? The scenario says that Mr. Martin is discharged back home. He's not able to maintain his health, his medications. He can't get to his doctor's appointments because he has limited transportation and has difficulty accessing it. So he's not going to his follow-up appointments readily or as he needs to. Mr. Jones has the support of his wife, as well as additional supports through a variety of means, and he's able to get to his follow-up appointments. He continues to stay in the community for the next many, many, many years until he dies, and he dies at home. Mr. Martin actually, after a period of time, is readmitted to the hospital after the emergency room visit because he got his medications all mixed up. He fell at home and then landed back in the nursing facility after a period of time at the hospital with a readmission. So I'm going to stop there. I really like to hear some feedback from you all. Is that a realistic scenario? Is that something you can relate to? Can you share with us anything that you may have experienced and dealt with related to that particular scenario that I've provided to you? And what do you think that has to do with social determinants of health? Ms. Howard, are you speaking? I see your mouth moving, but I can't hear you. Any feedback, any comments?
Barbara, I know I talked about my grandmother's last week, and I mean, the ethnicity aside, I mean, this is the exact trajectory that my two grandmothers had, you know, and the difference between their, you know, economic status and their education and their lifelong stability. I mean, basically the exact thing you said. My grandmother, you know, died, you know, receiving really good care and, you know, having access to all these appointments. And my other grandmother died, you know, in an emergency room or an ICU after many surgeries. I mean, you can just see like how the decisions, you know, that they made for themselves and people made for them over the course of their lifetime was dramatically different.
Right. And the primary one of the primary differentials, there probably were several. And again, the intersection of all of these particular things that may happen with any individual throughout their life is pretty complex. But I believe last week you shared with us that one of the primary differences is socioeconomic status.
Yes, socioeconomic status and education.
Yeah, yeah, good. Thank you, Justin. And as I continue to share information with you, you'll see that both of those categories are very significant in terms of health outcomes, as well as quality of life, as well as an individual's death experience even. Anybody
Barbara,
else?
there was a great comment this morning, and I don't know how you feel about this, but you know that old saying about money is the root of all evil? I'm wondering if money is the root of all social determinants of health.
Wow. Yeah. So yeah, wish it was that simple. Money definitely is very, very powerful and very impactful, and money influence a lot of decisions that are made, particularly in our healthcare systems. In some of the information I'll share with you a little bit later, you'll see some of this. I recently read a report where there you know, there was some discussion about how nursing facilities fared depending on where they were located, as well as depending on whether they were state funded, privately owned, or corporately funded. And you know, we can get into some deep conversation about what all of that means, but that particular study was very, very fascinating, and encourage you all, especially as being people who work in nursing facilities, to look at some of that information and research that's out there that helps us to understand this particular space a little bit better, but also helps us to understand decision making. Yeah, money does impact decision making as relates to how we provide healthcare, but it also impacts or has a phenomenal impact in this space of social determinants. The reason why I said it's a lot more complex than that, because social decisions, policy decisions, political decisions, the social justice issues that we have within our society here, as well as other places internationally, all of those things also impact the decision making, which in turn can have an impact and effect on a person's socioeconomic status. So let's just look here a little bit at the pure definition of social determinants of health, just, a really baseline or basic conceptualization of what it is that we're talking about here. And then we'll get into some specifics. But social determinants of health are the conditions in the environments where people are born, where they live, where they learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. And here in this particular slide, what you see is a chart or a diagram that helps us to see the various categories of social determinants of health that have been, again, discussed widely and broadly, as well as research. Some charts you might see have 5 categories. This one has 6, but many of them overlap as well. This one helps us to see some of these things we've already talked about briefly, that the categories of social determinants of health are economic stability, neighborhood and physical environment, education, food, community safety and social context, and health care or health systems. Excuse me. So underneath each of these categories, then it identifies the different conditions that or categories of conditions that may exist. Employment, for example, under economic stability is something that affects your economic status, your economic stability or lack thereof. The income, what your wages are, your expenses, cost of living, etc., whether you have debt, medical bills, as well as economic support that you may receive. Neighborhood and physical environment, really, really important. Location definitely has an impact on health outcomes. And I'll reference that a little bit more later in terms of just nationally, geographically, how where you live impacts life expectancy. Education, literacy, language, early childhood education, vocational training, higher education. Education has an impact on life expectancy, have an impact on health outcomes. It has even been demonstrated in some research that it has an impact on where you die. In Kentucky, I don't have literacy data for North Carolina, but I do know in Kentucky that we are still struggling with health literacy. Generally speaking, health literacy still, and we look at this often, of course, because we create, we promote, we produce documents and literature for the people that we serve, and we want people to be able to know it and understand it. And it is still deemed that we should make sure that anything that we produce that our patients, our clients, the people that we serve are going to read should be at a 6th grade level. So literacy is very, very important, and in the healthcare realm is critical if people are going to understand what their health conditions as well as what things that they need to do to manage their health are necessary. Food security, food and security. I will mention this again later, especially as it relates to the people who work in nursing facilities throughout our states as well as the country. It definitely has an impact on us, and I'll give a couple of examples of that. Community safety and social context. We've already talked to you quite significantly about social isolation, including the fact that people can be socially isolated in nursing facilities, definitely in the community, and how COVID has impacted and made social isolation even more pervasive than it was prior to the pandemic. But also, whether you have a support system, how engaged you are with your community, as well as the stress and strain of living in certain communities, exposure to violence and trauma, policing and justice policy, all of these things can impact health outcomes. Under the healthcare category, health coverage, in the scenario, we talked about the type of health insurance each of those individuals had and the potential impact that it may have on health outcomes. Provider and pharmacy availability. There are some communities, particularly in rural America, where there is limited access to pharmacists, to pharmacy, as well as to providers, to healthcare in and of itself. Access to linguistically and culturally appropriate and respectful care. Bottom line is, if a person is not able to understand or is not able to feel part of the care that they're receiving from a linguistic and a cultural perspective, then it's often very, very difficult for them to access that care, even if they're in the healthcare system. And then obviously the quality of the care. All of these things impact health outcomes, health and well-being. So just some consideration, if a person is homeless, living in unsafe or unhealthy conditions, or have limited access to food, this will greatly impact their health overall. Again, intersection of all of these categories does occur, is not insular. Not, one category may be present, but often there's a domino effect, or there's an intersection of all of these things occurring at the same time. I want you to consider a recent study also, which found that children experiencing food insecurity may have 2 to 4 times more health problems than children from low-income households who are not food insecure. So a person can be economically challenged, but have access to food. They're not food insecure, so those children are being fed, and their health outcomes fare much better than those who are food insecure and not able to access food. Similarly, adults who are food insecure are also at an increased risk of developing chronic diseases, such as obesity and diabetes. These poor health outcomes contribute to increased rates of readmission and non-compliance, which increases medical costs and risks. So if you consider the scenario that I provided for you earlier, you can see that if the conditions, the social determinants of health conditions and situations that are occurring with Mr. Martin, they're not mitigated if something is not provided to support him when he's discharged to home from the nursing facility. 9 times out of 10, he's going to have health crises that require him to go to the ER. He's remitted to the hospital, and then potentially is going to go back to the nursing facility for care, and may likely remain in the nursing facility until death. And this increases healthcare costs because this occurs pretty regularly with individuals who are challenged in these areas. And it impacts the health outcomes that health systems traditionally care about and measure. Quality, health status, readmissions, value, all of these quality measures are very, very important, especially in this day and time when those things are monitored by payer sources that we depend on to help support the care that we provide. Social determinants of health impacts who goes to the nursing home, the length of stay in the nursing home. It impacts even who dies in the nursing home. So this slide here goes even further to help us to see and understand the impact of social determinants of health and how they actually lead to premature death. They impact not only quality of life and health outcomes, but also life expectancy. For some, social determinants of health are also a predictor of where you die. For example, we know and understand that where a person lives can significantly impact their health, in a negative way or a positive way, depending on where that is. Zip code is a predictor of health outcomes. It influences health in a variety of ways. There are inequities in life expectancy. Life expectancy for the United States of America ranges from 66 years to 87 years. And as you can see in this particular map here, in the scale at the bottom where it says life expectancy at birth, 66 to 87, you can see that the lower levels help us to see where the life expectancy is the lower years, 66, and the darker blue areas is where life expectancy is higher. Recently, I was in a meeting and they were talking about blue zones. I don't know if you all know what blue zones are, but it's a fascinating phenomena where research have helped us to understand that we have these geographical locations in the world. There are not very many where people literally live to be over 100 up to 120 and beyond and live healthily. They have good health or up into those very, very late years of life. And I think we do have one is in California, in the United States, and then there's some in other parts of our world of our international regions. But these blue zones are the epitome of positive social determinants of health, where the negative impacts of the things that we've talked about so far today don't exist for most of the people who live in those particular regions of the world. In our country, you can see here that the Southeast, where we exist, Kentucky and North Carolina, have a whole lot more dark red than some of the other areas. But if I'm looking at this map correctly, North Carolina, you all are doing pretty good. You're not doing bad at all. What does that mean? What does that mean for any of us? What does that mean as it relates to location and zip code, et cetera? Historically, many of you probably have heard about redlining, for example. That's a policy decision that was made years ago that literally segregated populations of people in certain regions of their cities or where these geographical locations were, that prevented them from becoming homeowners, and a number of other economic and social policy decisions were made. And in that redlining decision policy continues to impact these communities and the people who live in these communities even today. There were decisions that were made about what type of businesses and factories, et cetera, that existed within these communities. And I can go on and on and on about other things that were decided, which all of this collectively have impacted the health of the individuals who live in these communities generationally over the generations of people who've lived in these communities since those decisions were made. And if you do any digging and research in this particular area, you don't have to dig far, you will see the health conditions of individuals in these communities are very, very different from the health conditions even in a neighboring zip code within the same city, within the same geographical location. So that just, I wanted to reference that mainly to just help us to understand that there is data, there's information, there's research out there that even help us to understand where nursing homes exist, impacts the health and care that's provided to the patients, the residents that you serve within your nursing facilities as well. It all compiles, and there's a collective impact for all of us as a result of the decisions that are made, the policies that are created, and how social determinants of health impacts each of us. And we're talking primarily, again, about the care of residents in our nursing facilities, but I'll have a slide here in a couple of minutes that will help us to know and understand that social determinants of health significantly impact the people who work in nursing facilities, particularly those who are, I try to never use the terminology lower level positions, but who are paid less, because our aides who work in nursing facilities, yeah, they may be paid less. They may, they requirements in terms of education, et cetera, are less, but they provide one of the most valuable services to the people that we take care of in nursing facilities, and are very, very important, but they are definitely impacted by the social determinants of health and may be in crises as they work with the people that we serve. So social determinants of health in nursing homes, the impact on residents. There's a study that I reference here where they learned that the length of the last nursing home stay before death is not only dependent on health-related factors alone, as we've already discussed, but also substantially dependent on socio-demographic determinants such as educational level, home ownership, or marital status. And that's a study that's done by Hedinger et al., BMC Geriatrics. It has been shown that health-related determinants such as some causes of death like dementia and stroke, as well as social determinants such as low educational level, significantly increase the probability to die in a nursing home. Advanced age, not having a home or a partner, low educational level, sedentary lifestyle, poor self-rated, health status, high number of drug prescriptions, and functional and cognitive impairments are the main predictors of the institutionalization process. Excuse me, the study that I just referenced here, it provides evidence that the same determinants significantly increase the probability of a longer terminal nursing home stay as well. Medical and or care needs also, excuse me, several, my goodness, I do have some water. Let me drink a little water. I'm sorry. But also several not directly health-related factors influence nursing home admission and stays. Social inequalities are not only present with regard to place of death, but also in the duration of the last nursing home stay before death. They found evidence of such inequalities in both sexes. A low educational level, living alone, or being tenant, as well as a low care level at the beginning of the last nursing home stay, increased the risk for longer terminal stays. On the other hand, a high educational level, being a homeowner, and being married, as well as a high care level at the beginning of the last nursing home stay, or hospitalization even, in the last year of life, decrease the risk for longer stays. So you can see the variance or the comparison of the different social determinants and how they impacted a person's time in the nursing facility, as well as repeat hospitalizations. Compared to men, the terminal stay of women is on average 1/3 longer, but the role of socio-demographic factors is similar for both sexes. In another study that I found, it found that people were more likely to move out of their home into an institution if they had no social network. That again provides the emphasis on how important social supports, having a good, strong social circle of supports is for individuals later in life, or individuals who have chronic health conditions. Older adults who enjoy going to the movies, dinner, who were social, who were engaged, who were active in their communities, visiting family or friends, had a lower probability of institutionalization compared to participants who did not enjoy these activities, or did not visit families and friends, or maybe didn't even have families and friends to visit. They were limited in that area. So I had indicated to you earlier that social determinants of health also impact staff. Research showed that healthcare support staff experience social determinants of health like food insecurity more than clinicians like doctors and nurses. And that's just, again, so important for us to consider as we acknowledge, learn about, and inform ourselves about social determinants of health and the impact that it has on our nursing facilities. Many individuals who work in nursing facilities, particularly the aides, are going to be individuals who may have a lot more experience in the negative impact of social determinants, the social economic limitations, uh, the environmental concerns, where they live, where they exist, as well as healthcare and access to healthcare. And we can go through every category. But I referenced in this particular study that they found that food insecurity is definitely an area of social determinants that many of the people who work in nursing facilities experience. So just generally speaking, addressing social determinants of health is important for improving health and reducing health disparities. Addressing social determinants of health overall in our society is important for all health systems, including nursing facilities. Addressing social determinants of health, creating policies that impact change, et cetera, I think could impact nursing facilities in a very positive way from a variety of perspectives. Though healthcare is essential to health, it is a relatively weak health determinant. Again, that's not to say that it's not important, it's not critical, but it is not the dominant determinant to health outcomes. Research is continuously helping us to understand this better. It shows that health outcomes are driven by an array of factors, including underlying genetics, health behaviors, social and environmental factors in healthcare. While there is currently no consensus in the research on the magnitude of the relative contributions of each of these factors to health, studies suggest that health behaviors such as smoking, diet, and exercise, and social and economic factors, as we've been discussing this afternoon, are the primary drivers of health outcomes. And social and economic factors can shape an individual's health behaviors. Again, sharing and explaining that intersectionality of all of these particular areas, these determinants of health. If you have limited social economic status, then it can definitely influence your health behaviors in a variety of ways. For example, children born to parents who have not completed high school are more likely to live in an environment that poses barriers to health, such as lack of safety, exposed garbage, and substandard housing. They also are less likely to have access to sidewalks, parks, or playgrounds, recreation centers, or a library. And all of those things obviously influence health behaviors. Further evidence shows that stress negatively affects health across the lifespan, and that environmental factors may have multi-generational impacts. Environmental factors can create and produce stress, expose individuals to trauma, etc. Addressing social determinants of health is not only important for improving overall health, but also for reducing health disparities that are often rooted in social and economic disadvantages. It is important for us to reflect in this area, in this space, not only to be able to serve our residents better in nursing facilities, but also to help us to provide, the things that are needed to our staff who are working with the residents to provide them with good care. As I had indicated earlier too, there's literature and research out there that's helping us to understand some of the things that were exposed as a result of the pandemic, as a result of COVID. And one article that I read gave a lot of emphasis in the area through their research on where nursing facilities were located and how that impacted their response to COVID, as well as their exposure to COVID during the early parts of the pandemic. And it was interesting to see, again, this is just helping us to again understand the social determinants of health as it relates to nursing facilities. It was interesting to see that there was some differential as it relates to location in urbanized areas versus smaller communities, differential as it relates to the southeast part of Kentucky as compared to other regions, southeastern part of our country as compared to other regions of our country. The differentials being related to policy, social policy, culture and decision-making, as well as and particularly in urbanized areas in comparison, differences related to staffing patterns, et cetera. So wanted to just share that little bit of information with you. This particular presentation mainly was to expose you to social determinants of health and the potential impact that it has on the people that you serve, as well as staff who work in your facilities, in hopes of, again, piquing your interest, knowledge, as well as decision-making going forward in this particular area. I'm going to stop there. We are just a little bit past 2:45. We have some time for questions and discussion. I'm hoping that some of you might have some things you want to share during this time. We can get into some really interesting, robust discussion. I see Daynell put the blue zone areas in the chat. Thank you, Daynell. Did you put oh yes, it's Loma Linda, California. That is, I think, the only spot in the US that is considered a blue zone. And that's worth looking into as well. As fascinating information out there about that. Yes, and redlining does continue to affect communities today. It has long-lasting impact. Any questions or discussion? What are some suggestions you may have for your own nursing facilities, and maybe even go back to the scenario that we provided with Mr. Martin and Mr. Jones? What are some suggestions you may have in terms of things you could do in your nursing facilities to potentially impact individuals who've experienced social determinants of health over their years of life that has impacted them negatively?
Barbara, I'm really curious, are there outside organizations that facilities could work with to address this in their residents if they are, really deficient in one of those areas?
For nursing facilities specifically, I don't know of any. There are many national health systems or organizations, et cetera, those who are in the healthcare space, I think it's National Association for Hospital Systems. I may not be saying these organizations actually correctly, but they are doing some work in this space. They are, they're doing a lot of studying and research, obviously, as I shared throughout the presentation, but they're also beginning to identify potential policy suggestion and changes. So that's, but for nursing facilities specifically, don't see a whole lot. CMS, however, they have done quite a bit as it relates to Medicare payment, Medicare Advantage plans in particular, in helping providers, hospitals even, as well as the insurance companies who provide Medicare Advantage plans to cover the cost in areas of transportation, food security, et cetera, to try to help mitigate some of the limitations that people experience as a result of social determinants of health. So the answer to your question specifically is I don't know of any specific organization entity that is working specifically on nursing facilities, but there is a lot going on as it relates to health systems overall.
And I'm wondering, like, so, like, if we go back to your case examples, and you have the gentleman that really is struggling, um, are area agencies on aging helpful for people who are maybe wanting to go back home after the rehabilitation?
Right. Right. So if we go back to the case scenario, and thanks for taking us back there. So, what could a nursing facility do upon discharge to try to help build in some of those supports? Obviously, for Mr. Jones, it's easy. He's got a great support system. You're going to double check and make sure that that's accurate, that everything's in place. But for Mr. Martin, it's not so simple, not so straightforward. So your discharge, the person, so most of the time is social work staff or the director of social work in our facilities. It would be good for them to, hopefully they already know all of the community supports in their community. If they don't, they can definitely contact the area agency on aging that serves their community. And they should be able to help them through programs and services that they provide themselves and or other organizations that they're connected with in the community who provide services. But the idea there is to try to build him a circle of support that is going to be able to help him with medications, for example, that's going to be able to help him with transportation to get to and from his doctor's appointments. That's going to help to get healthy meals in his home daily, if possible, or minimally 5 days a week. And yes, the area agency on aging can help with that in most communities. I have to always say when I talk about that area agencies on aging depend on public funds, and sometimes there are waiting lists for some of these services. But the other thing that might be available to Mr. Martin, especially because he has Medicaid, is home and community-based waiver services. So you can look at a multiple potential programs and services that can help build that social circle of supports. And through home and community-based waiver in many states, you can have access to in-home services like personal care and homemaking, and you can have access to transportation. You can have access to home delivered meals, medication management. So there's a number of things through home and community-based waiver services, and that's funded and supported through Medicaid. In some states, you may even have the home transitions program. That's a part of Medicaid waiver, where it's the CMS language for that program is money follows the person. So individuals in your nursing facilities who are interested in going home, literally the money follows the person. The Medicaid system is supposed to help that person to establish the things that they need to be able to live at home rather than in a nursing facility. And again, it helps to build those circle of supports. So yeah, there are options. I know if there are any social service directors on the call from a nursing facility, they're probably thinking, wow, that's a lot. I'm not sure that I would even have time to do that with individual residents. Well, you may not have a whole lot of time to do all of those things, but if you are looking for a Medicaid waiver, if you're working with the area agency on aging, they're supposed to work with you collectively. So all of the burden of trying to help make sure these things are in place in your community is not on you or the nursing facility, but you work in partnership to try to make sure those things are available. I would also recommend that if you can establish and know and understand what residents know upon a warrant upon admissions, because I know most people don't want to spend the rest of their life or die in a nursing facility. And many of your residents do come as a result of a discharge from a hospital. If you can know what they potentially might want to do when they are able to be discharged to home, what they want, then you can start making some of those connections before they even get to that point. And then some things can be established already. Any other questions or comments? Okay, it's 2:55, Justin. I'm going to advance the slide.
Thank you, Barbara. And for some reason, it doubled it up, so I apologize. If you have a case that you'd like to submit for next week, we really appreciate it. You can either use the QR code or you can use the link that's in the chat. And if you'll advance to the next slide, as always, we do have a short session survey at the end. We do read those and pay attention to those. So please, if you complete that, and we'll be around if you have any questions or comments. Otherwise, we hope you have a great rest of your week, and we hope to see you next Thursday for week 24.